Bismillahirrahmanirrahim. Assalatu wassalamu ala rasulil kareem. Assalamu alaikum. First of all, I want to thank Dr. Padela, his leadership vis-a-vis this program, this institute, the Aasim, our participating groups in terms of our working group arrangement, Templeton Foundation, and all those that are contributing to this. I've been coming to these things, these events, these programs for some time. And I just want to say that Aasim's threatened to not host a couple of times out of frustration and sheer amount of work that it involves. So it's good to see the kind of support by us showing up and adding to the conversation. This is sort of our emerging expert community, so everybody here has something to offer, some degree of expertise. So share that in a collegial fashion and exchange is really critical to the growth of this field. So thank you, all of you, Aasim, specifically you. As Aasim had mentioned about the working group, 6 or 7 of us had been getting together and trying to understand a myriad of concepts in the auspices of 2 questions. The second question pertains to me, and it was basically about soul and how are its capacities manifested physically. As a neurologist, this to me obviously applies rather immediately to the brain. But my personal experience, just so you know, in going through this exercise of the working group, has been just exposed to the vastness of literature, both within the philosophy of mind, then the Islamic philosophy of mind, and rather within my own field of neurosciences. We have some clinicians here in neurology, and many of us are not formally trained in science of consciousness. It's been the realm of psychologists and psychology. But we deal with this every single day, or implications of it. So I've personally found this exercise to be of tremendous benefit and tremendous growth that impacts my own clinical insights. As our discussions continued in this field, I noted and I realized that a lot of work we do clinically in the clinic, in ICU, in the emergency rooms, in the clinical settings, is rapid triaging of patients. And the first thing we encounter often is awake, aware, or unconscious patients. And that's how we prognosticate how one is going to potentially survive or one is not going to survive, or what will be the nature of meaningful survival or meaningful recovery. Clinicians know this very well. This is done very rapidly. And I often do get this feeling that we don't really have a chance to absorb or potentially evaluate the broader constitution that defines that human as a person. Because there's a lot of psychosocial factors going on within that person, in that person, and in and around that person vis-a-vis his or her family. Those are all important in terms of how we ultimately choose to treat. But for diagnostic purposes, these are clinical tools that are such as Glasgow Coma scales and other clinical tools. They're very important to us, and they do give us immediate information at our disposal. So we cherish them, but in our discussions, we like to expand our understanding, especially vis-a-vis a mind-body problem, to the whole psychosocial constitution of that individual. So it is here within this working group that I began to focus on studying consciousness and understanding the metaphysical elements that you just mentioned. And it is here that we stumbled upon the challenges that within the field of neurology. And what we conclude, and what many other experts conclude, is there really isn't a very simple, comprehensive neuroscientific theory of consciousness. There's none that exists. There's myriad of theories, some competing, some contradictory to each other, but it's not, that's our hard problem in neuroscience. That's a shortcoming. I just like to put this up because I think this puts something in perspective for the devout, at least. You don't have a soul, you are a soul, you have a body. There's another way to look at things. But in studying this, very quickly we realize that from the philosopher's point of view, there's skepticism of scientific approach. The scientific approach, as you have gleaned, is turned quite materialistic and reductionist, meaning that from a neuroscience perspective, brain as a matter is a sole entity that will process all your mental faculties. And there are no other elements, such as non-material sources. But I think that puts a lot of philosophers at unease. And then we see the skepticism and schisms, and skepticism from Muslim and non-Muslim philosophers, and this is an example of what we won't clinically deal with, but it's a stark statement that the profound reality of our consciousness cannot be just eradicated by accident of bodily death, by Sayyid Hussein Nasr and many other philosophers that echo that. Thoughts, sensations, feelings, and intentions do not have mass, momentum, shape, spatial location, spatial extension, or temporal location. They are neither particles nor waves, meaning material objects do possess some spatio-temporal properties. Since conscious states lack the properties of material objects, it follows that consciousness is neither identical with nor reducible to matter. Another example of skepticism countering the idea of a pure reductionist materialist philosophy that your entire mind is solely encompassed in your brain as a physical organ. So focusing on consciousness, I'd like to just briefly touch upon the neuroscience of it and just give you a glimpse into the philosophy of mind discussions around it. Now, because we're talking about consciousness and or alteration of mentation as it pertains to it, and I'm from California, I would say, Hassan, I should have some disclosures. You know what disclosures are? Disclosures, for physicians have to disclose if they have investments in any drugs or any other entities that will bias us. So I can assure you that I have not invested in any of the marijuana dispensaries in my neighborhood, and no, none of the companies that are making marijuana drugs, and I hope yours is not one of them. So, not yet. But let us know when the stocks go on the market, and then maybe we can have a fatwa issue that Muslims can invest in that. So consciousness. What we generally look at consciousness. In the early definitions of consciousness, was known to be an active process, and that was sufficient. It's awareness of oneself. Expanded definition when brain structures were identified, like more recent within the last few decades, the human consciousness became both self-awareness and awareness of the environment. So you have to be able to interact. We evaluated at two levels. One already mentioned by your group. That's a level of consciousness. The level involves alertness, awareness, attention. And then content of consciousness, which is often the realm of discussion in mind philosophy debate. The contents of consciousness, or what we call content consciousness, is comprised of systems that mediate sensory, motor, memory, and emotional functions. This here is a basic schemata that, based on latest research, am I going to get it? Yeah. Based on latest research, this area in the brain is called thalamus. And these are what we call midline structures. This area is brainstem. So one would appreciate from this slide that these midline structures are connected to the rest of the brain, called newer brain structure, forebrain structures, also called cortex. So there's connectivity in the brain all across the brain and simultaneously in a much often synchronized fashion. This center here allows for consciousness to be present in the brain. At least that's what we believe from latest data. So levels of consciousness, just breaking it down again into those three levels: attention, awareness, and alertness. So for alertness, wakefulness is required. You have to be awake to be alert. And I'm going to skip some of the details here there in the slides, but one example of lack of awareness, lack of alertness is coma, as you mentioned. That involves any absence of awareness altogether. That's a comatose person. We have identifiable structures within the brain where coma can emanate from. Again, those are midline structures. This is one area, if it's damaged, there's no wakefulness at all. And if there's no wakefulness and the higher brain areas are suppressed, one would be in a comatose state. That's a proven fact. Another level of consciousness is aware. So one could be alert but may not necessarily be aware. And that's an example of what we call persistent vegetative state. In other words, a lack of awareness, but some level of alertness being present could constitute what we call persistent vegetative state, and a myriad of different structures. Again, in the pink, these central structures are often involved in that processing. And lastly, I'll mention attention. Attention becomes the key prerequisite for consciousness, period. Attention is related to perception, is our ability to select alternatives. In the minimally conscious state, which is the latest state in the disorders of consciousness defined, one may be alert, meaning not in a coma state. One may be aware, meaning not in a vegetative state, but lacks some degree of attention. But that person is not in a coma, that person is not in vegetative state. That patient will be considered to be in a minimally conscious state. So those are just definitions. And here's some schemata. It's in the slides, but this brain is all grayed out, which just means that there's no function in the brain. This is considered brain death, and so on and so forth. The blue areas are areas of minimal function. So this example takes us from the fact that one can be brain dead to coma to vegetative state to minimally conscious state to states where you just have no motor movements, and to state which what we call locked in syndrome, in which you have a small area of damage here, but you're unable to do anything but open your eyes, essentially. So these are all considered diagnoses within the disorders of consciousness, and there's a table in the slides that marks what functions are present, what functions are absent in that setting. Content consciousness. I want to move on to content consciousness. So consciousness classification has been a difficult thing for neuroscience. There are different classifications. One classification that I find useful is just divided maybe in 4 categories, and look at it as one being self-aware. That's one category, self-aware, meaning I know I'm here and I know you're there. Just relational self-awareness. Second is higher order awareness. Now this is abstract reasoning, our ability to understand our past, present, future. And C is medical awareness, meaning we're either awake, responsive, or we're not medically aware, meaning maybe we are in a comatose state, which means we have no medical awareness. And lastly, consciousness as an experience, which we call phenomenal consciousness, or qualia, which is an experience, like content consciousness. This involves a lot of perception. How do you perceive pain? We know exactly in the brain where pain is potentially produced or processed. But how do you translate from that area of those nerves firing to actual perception or an experience of pain? How does one define that qualitatively or even quantitatively? Those are what creates a lot of schism within neuroscience, and what I believe doesn't really allow us to produce a good comprehensive scientific theory of consciousness. But also this is here we really appreciate the complexity within the brain of the need for integration of information. Information in the brain as processed in different centers must have to be integrated to give us a very deep, meaningful experience. For example, pain or emotional experiences. It's not as simple as breathing. I mean, we're not conscious of our breathing, right? Breathing is just a subconscious process. I mean, unless you're doing Sufi meditation, you may not need to necessarily be aware of your own breathing and survival. But that's another very important thing, because you can bring that subconsciousness to your conscious level by making that focused attention on that in that specific area. But in this case, the experiences, we don't have a satisfactory enough theory to give us a satisfactory answer in terms of the experiential properties of the brain. And this is what in neuroscience we call the explanatory gap, meaning how does the physical activity in the brain really turn into an experiential process? How does it become an experience? How do I see if I see a red dot, I know which centers of the brain fire, but how do I know it's red? What tells me it's red? So that's an experience, it's an experiential phenomenon. Then what happens to a person who's colorblind? Does that person then lack that content of consciousness because he or she is unable to process or gain that meaningful experience? So those are all debates that are raging, but we throw in other terms, you'll hear quite a bit, it's called neural correlates of consciousness. The neural correlates are all these various elements that go into processes within the brain. So structures, different portions of the brain, the binding properties of the brain, the information, how it's brought together, the rhythms within the brain. For example, research says that 40 hertz rhythms in the brain are a prerequisite for any conscious experience. And how much time does it take to get meaningful experience or meaningful expressions? Generally, we think it's 200 to 500 milliseconds, and what delay goes in there. So all these neurochemical processes are all correlates of consciousness. So assessing consciousness. Again, not in a clinical setting, if you're a critical care neurologist and you're assessing consciousness from a point of view where the person is awake or in a coma state, it's relatively easy to do. if you're trying to look for basic contents of consciousness and you say, well, we don't, these experiential phenomena, we don't know how to really translate the areas of the brain that are firing on functional MRI to really what transpires within the what transpires within the experiential what transpires into an experience. That's a tough one. So, and here the area of the brain that processes the consciousness or integrates it is called prefrontal cortex, visual cortex, where visual information is processed. So those are also proven by research, but this requires integration. But that integration is also relatively easy to break. You can break it under anesthesia. You can also disrupt integration if one is intoxicated. So that integrated properties are broken, and thus you're operating at subpar conscious levels. This here is just to really scare everybody, but just to impress upon also that there are different areas of the brain that are specialized to process all of these modalities: alertness, awareness, sense, perception, memory. And ultimately, the problem here is that how does all this information integrate to have you and I be walking, experiencing human beings? We don't really have a comprehensive answer to do that. Some of these are in the slides. I just want to mention that cognition is an important part of our consciousness. Memory comes in that. Alzheimer's patients cannot process abstract thought at some point. Does that mean they're processing at a subconscious level? That's an important question to ask. Muslim clinicians have to ask that question. As we contend with the idea of soul, of course, as we contend with the idea of soul, we're not treating soul as physicians. We're treating the body, right? I mean, I'm not in the business of healing the soul per se. I mean, I could be if you really push me to it, but at the end of the day, I go in a room and I declare a patient either in a comatose state or brain death state. The issue becomes that's not necessarily what the families are looking for. Oftentimes, our families are looking for the fact that, look, this person, what's this person's status vis-a-vis akhirah? This is what we discussed in the working group. But do we have a little bit more time to make dua for this person, for his maghfirah, meaning his forgiveness? I mean, those are some of the thoughts that are going through their mind, but those are matters of the soul, which I always like to defer to Sheikh Jihad Brown, given that he's the expert in it. Concluding point is that in our paper, we're exploring the scientific theories of consciousness, and we haven't found a comprehensive enough theory that integrates all the brain's information and impresses upon us that beyond just the physical entity that the brain is, that brain alone is able to give that experiential quality to the mind. Thank you very much.